Welcome to this Critical Care Nclex Mastery session on Hemodynamic Monitoring, CVP, and MAP. These 50 difficult questions will challenge your ability to interpret pressure trends, recognize shock patterns, evaluate perfusion, and make the safest clinical decisions under pressure. Stay focused. Some of these questions are designed to expose the subtle mistakes that even experienced candidates make. Question 1. A 72-year-old client is admitted to the ICU with septic shock caused by an intra-abdominal infection. After receiving an initial crystalloid bolus, the client remains hypotensive with a blood pressure of 78/46 mmHg. The MAP is 57 millimeters of mercury. Heart rate is 126 per minute. Urine output is 10 milliliters per hour, and the client is increasingly confused. The CVP is 3 millimeters of mercury. The healthcare provider prescribes a vasopressor infusion and asks the nurse to continue monitoring the client's response. Which finding provides the strongest evidence that the client's current hemodynamic state is compromising organ perfusion? A. CVP of 3 millimeters of mercury. B. Heart rate of 126 per minute. C. Urine output of 10 milliliters per hour with new confusion. D. Blood pressure of 78/46 millimeter of mercury. Answer: C. Urine output of 10 milliliters per hour with new confusion. Rationale: the combination of severe oliguria and acute change in mental status provides direct clinical evidence that vital organs are not receiving adequate perfusion. Although the low MAP and tachycardia are concerning, urine output and neurologic status demonstrate the consequences of inadequate systemic perfusion. A low CVP may suggest reduced right-sided filling pressure, but does not by itself establish organ hypoperfusion. Question 2. A client with acute right ventricular failure is receiving mechanical ventilation in the ICU. The nurse observes a CVP of 18 millimeters of mercury, MAP of 64 millimeters of mercury, urine output of 15 milliliters per hour, jugular venous distension, hepatomegaly, and increasing peripheral edema. The client's lungs remain relatively clear. The healthcare provider asks the nurse to interpret the elevated CVP. Which interpretation is most appropriate? A. The elevated CVP may primarily reflect impaired right ventricular emptying rather than simply excessive circulating volume. B. The elevated CVP proves that the client has adequate cardiac output. C. The elevated CVP indicates that systemic vascular resistance is severely reduced. D. The elevated CVP confirms that additional large-volume crystalloid administration is required. Answer: A. The elevated CVP may primarily reflect impaired right ventricular emptying rather than simply excessive circulating volume. Rationale: CVP reflects right-sided filling pressure and is influenced by right ventricular function, venous return, intravascular volume, intrathoracic pressure, and mechanical ventilation. Severe right ventricular dysfunction can cause blood to back up in the systemic venous circulation, producing a markedly elevated CVP. Therefore, a high CVP does not automatically mean that the client needs more fluid. Question 3. A postoperative client develops hypotension several hours after major abdominal surgery. The client has a BP of 88/50 mmHg, MAP of 63 millimeters of mercury, CVP of 2 millimeters of mercury, HR of 132 per minute, cool clammy skin, and urine output of 12 milliliters per hour. The nurse reviews the previous hemodynamic measurements and notes that the CVP was 8 millimeters of mercury immediately after surgery, but gradually decreased to 2 millimeters of mercury as the client's blood pressure declined. Which pathophysiologic process best explains this pattern? A. Progressive right ventricular failure causing systemic venous congestion. B. Increased intrathoracic pressure causing impaired venous return. C. Acute increase in left ventricular afterload causing pulmonary congestion. D. Progressive reduction in venous return resulting in decreased preload and cardiac output. Answer: D. Progressive reduction in venous return resulting in decreased preload and cardiac output. Rationale: the falling CVP accompanied by hypotension, tachycardia, cool skin, and oliguria suggests decreasing right-sided filling and preload. In the postoperative setting, occult blood loss is an important possibility. Reduced venous return decreases ventricular filling and can ultimately reduce cardiac output and systemic perfusion. Question 4. A client with septic shock has received appropriate initial fluid resuscitation. The nurse obtains the following measurements. BP, 92/48 mmHg. MAP, 63 millimeters of mercury. CVP, 10 millimeters of mercury. HR, 118 per minute. Urine output, 20 milliliters per hour. Lactate, increasing. Skin, warm with bounding peripheral pulses. The healthcare provider plans to initiate a vasopressor. Which explanation best supports this intervention? A. The CVP indicates that the client has no circulating blood volume. B. The MAP remains inadequate despite initial volume replacement, suggesting the need to improve vascular tone and perfusion pressure. C. The elevated heart rate proves that the client is experiencing cardiogenic shock. D. The warm skin confirms that tissue perfusion is already adequate. Answer. B. The MAP remains inadequate despite initial volume replacement, suggesting the need to improve vascular tone and perfusion pressure. Rationale. In septic shock, profound vasodilation can persist after initial fluid resuscitation. A MAP of 63 millimeters of mercury with ongoing evidence of inadequate perfusion may require vasopressor therapy to restore vascular tone and maintain an adequate perfusion pressure. The elevated CVP does not establish that tissue perfusion is adequate. Question 5. A mechanically ventilated client with severe ARDS has a CVP of 14 millimeters of mercury. The nurse notes that the CVP increased from 7 to 14 millimeters of mercury after the positive end expiratory pressure, PEEP, was increased substantially. The client's blood pressure has decreased and urine output has fallen. There is no evidence of new fluid administration during this period. Which interpretation of the CVP change is most appropriate? A. The elevated CVP proves that the client has developed severe fluid overload. B. The elevated CVP confirms improved right ventricular function. C. The increased intrathoracic pressure from higher PEEP may have increased the measured CVP and impaired venous return. D. The CVP increase demonstrates that cardiac output has increased. Answer. C. The increased intrathoracic pressure from higher PEEP may have increased the measured CVP and impaired venous return. Rationale. CVP is affected by intrathoracic pressure. Increasing PEEP can raise intrathoracic pressure and consequently increase measured central venous pressure. High intrathoracic pressure can also impede venous return and reduce cardiac output, potentially contributing to hypotension and decreased urine output. Therefore, the elevated CVP cannot automatically be interpreted as fluid overload. Question 6. A client with acute myocardial infarction develops cardiogenic shock. Hemodynamic monitoring reveals a CVP of 15 millimeters of mercury and a MAP of 55 millimeters of mercury. The client is pale, diaphoretic, confused, and producing 8 milliliters per hour of urine. The lungs contain bilateral crackles. Which additional finding would most strongly support the interpretation that the client's elevated CVP is related to cardiac pump failure rather than simple hypovolemia? A. Continued oliguria despite the elevated filling pressure. B. Dry oral mucous membranes. C. Flat neck veins when positioned at 45 degrees. D. A further decrease in CVP after passive leg elevation. Answer. A. Continued oliguria despite the elevated filling pressure. Rationale. The client already has evidence of increased filling pressure, pulmonary congestion, hypotension, and poor organ perfusion. Persistent oliguria despite an elevated CVP supports the presence of impaired forward cardiac output and pump failure. The other findings would be more suggestive of reduced intravascular volume. Question 7. The nurse is caring for a critically ill client whose arterial blood pressure is 110/50 mmHg. The monitor calculates the MAP as approximately 70 millimeters of mercury. The client is awake, warm, and producing 45 milliliters per hour of urine. A new nurse states, the systolic pressure is high, so the client must have excessive tissue perfusion. Which response by the experienced nurse is most accurate? A. Correct. Systolic pressure is the most important pressure for determining organ perfusion. B. Correct. A systolic pressure above 100 millimeters of mercury rules out inadequate perfusion. C. The MAP is more useful for estimating the average pressure driving systemic circulation, and the client's current MAP is approximately 70 millimeters of mercury. D. The MAP cannot be interpreted unless the CVP is above 10 millimeters of mercury. Answer: C. The MAP is more useful for estimating the average pressure driving systemic circulation, and the client's current MAP is approximately 70 millimeters of mercury. Rationale: MAP represents the average arterial pressure throughout the cardiac cycle and is commonly used when evaluating systemic perfusion pressure in critically ill clients. A systolic pressure alone does not determine whether organ perfusion is adequate. In this case, a MAP of approximately 70 millimeters of mercury is generally within an acceptable range for many critically ill adults, although individual targets vary. Question 8. A client with severe pancreatitis develops hypotension and oliguria. The nurse notes a CVP of 1 millimeter of mercury, MAP of 58 millimeters of mercury, HR of 138 per minute, and cool extremities. After an appropriate fluid challenge, the CVP increases to 6 millimeters of mercury and the MAP increases to 69 millimeters of mercury. Urine output subsequently increases to 35 milliliters per hour. Which interpretation best describes the client's response? A. The client has developed cardiogenic shock because the CVP increased. B. The increase in CVP and MAP, followed by improved urine output, is consistent with improved preload and systemic perfusion. C. The CVP should have remained below 2 millimeters of mercury for adequate perfusion. D. The increase in MAP demonstrates that the client is now fluid overloaded. Answer: B. The increase in CVP and MAP, followed by improved urine output, is consistent with improved preload and systemic perfusion. Rationale: the client initially demonstrated findings consistent with reduced preload and inadequate perfusion. Following fluid administration, the CVP increased moderately, MAP improved to 69 millimeters of mercury, and urine output increased. The simultaneous improvement in hemodynamic and clinical perfusion indicators supports a beneficial response to volume replacement. Question 9. A client in the ICU has a CVP reading that suddenly changes from 8 millimeters of mercury to 18 millimeters of mercury. The client is clinically unchanged, with stable blood pressure, heart rate, respiratory status, and urine output. The nurse assesses the monitoring system and finds an air bubble in the pressure tubing and a loose connection near the transducer. Which action should the nurse take? A. Administer a fluid bolus immediately. B. Notify the provider that the client has acute right-sided heart failure. C. Administer a diuretic because the CVP indicates fluid overload. D. Correct the monitoring system problem and obtain a new CVP measurement. Answer: D. Correct the monitoring system problem and obtain a new CVP measurement. Rationale: a sudden isolated change in an invasive pressure reading without corresponding clinical deterioration should prompt assessment of the monitoring system. Air bubbles, loose connections, improper leveling, and other technical problems can produce inaccurate measurements. The nurse should correct the equipment problem and reassess before initiating treatment based solely on the questionable value. Question 10. A client with severe sepsis remains hypotensive after initial fluid resuscitation. The nurse obtains a BP of 84/54 mmHg and a CVP of 12 millimeters of mercury. The calculated MAP is approximately 64 millimeters of mercury. The client is confused and has produced only 15 milliliters of urine during the past hour. Which assessment finding would be most important to trend when evaluating whether systemic perfusion is improving? A. The client's MAP together with urine output and mental status. B. CVP alone because it directly measures cardiac output. C. Heart rate alone because tachycardia is the primary determinant of organ perfusion. D. CVP together with the client's total oral fluid intake. Answer: A. The client's MAP together with urine output and mental status. Rationale: evaluating systemic perfusion requires integration of hemodynamic measurements with evidence of end-organ function. MAP provides information about perfusion pressure, while urine output and mental status provide clinically meaningful evidence of renal and cerebral perfusion. CVP alone does not directly measure cardiac output or guarantee adequate tissue perfusion. Question 11. A 64-year-old client is admitted to the ICU after an extensive anterior wall myocardial infarction. The client develops hypotension despite receiving an initial fluid challenge. Hemodynamic monitoring shows a CVP of 16 millimeters of mercury and a MAP of 56 millimeters of mercury. The client is dyspneic, has bilateral crackles, cool extremities, and a urine output of 12 milliliters per hour. The nurse notes that the CVP has progressively increased from 9 to 16 millimeters of mercury, while the MAP has continued to fall. Which intervention should the nurse anticipate? A. Rapid administration of another 2L of isotonic crystalloid. B. Positioning the client flat with the legs elevated for prolonged venous loading. C. Administration of therapy to support cardiac output and systemic perfusion while avoiding unnecessary volume loading. D. Restricting all vasoactive medications because the elevated CVP indicates adequate perfusion. Answer: C. Administration of therapy to support cardiac output and systemic perfusion while avoiding unnecessary volume loading. Rationale: the combination of markedly elevated CVP, pulmonary congestion, falling MAP, oliguria, and a recent myocardial infarction is consistent with impaired cardiac pumping and cardiogenic shock. Additional large-volume fluid administration may worsen pulmonary congestion. Management may require vasoactive or inotropic support and treatment directed at the underlying cardiac dysfunction. Question 12. A client with septic shock has an arterial blood pressure of 102/38 mmHg. The nurse calculates the MAP as approximately 59 millimeters of mercury. The client is receiving a prescribed norepinephrine infusion. Which finding would provide the best evidence that the vasopressor therapy is improving systemic perfusion? A. Heart rate increases from 108 per minute to 126 per minute. B. CVP increases from 5 millimeters of mercury to 9 millimeters of mercury. C. Systolic blood pressure increases from 102 to 118 millimeters of mercury. D. Urine output increases from 10 milliliters per hour to 40 milliliters per hour with improved mental status. Answer: D. Urine output increases from 10 milliliters per hour to 40 milliliters per hour with improved mental status. Rationale: improvement in urine output and mental status indicates improved renal and cerebral perfusion. Although blood pressure and CVP are important measurements, the goal of restoring MAP is ultimately to improve tissue and organ perfusion. A rise in systolic pressure alone does not prove that perfusion has improved. Question 13. A client with severe hemorrhagic shock has a CVP of 1 millimeter of mercury and MAP of 52 millimeters of mercury. After blood products and crystalloid are administered, the CVP increases to 7 millimeters of mercury. MAP rises to 67 millimeters of mercury. Heart rate decreases from 138 per minute to 108 per minute, and urine output improves. Which conclusion is most appropriate? A. The client is demonstrating a favorable hemodynamic response to volume replacement. B. The increased CVP indicates the development of right-sided heart failure. C. The MAP is too high and indicates excessive tissue perfusion. D. The reduction in heart rate indicates worsening cardiac output. Answer: A. The client is demonstrating a favorable hemodynamic response to volume replacement. Rationale: the client's CVP and MAP increased while heart rate decreased and urine output improved. These changes collectively suggest improved preload, cardiac output, and systemic organ perfusion. A moderate increase in CVP following appropriate volume replacement does not by itself indicate cardiac failure. Question 14. A mechanically ventilated client has a CVP of 13 millimeters of mercury and a MAP of 66 millimeters of mercury. The nurse observes that the CVP fluctuates significantly with the respiratory cycle. The client is receiving high levels of PEEP and has worsening oxygenation. Which factor should the nurse consider when interpreting the CVP? A. High PEEP can increase intrathoracic pressure and influence the measured CVP. B. PEEP has no effect on central venous pressure measurements. C. A high CVP during mechanical ventilation always indicates excessive circulating volume. D. The CVP should be interpreted as an exact measurement of ventricular preload regardless of airway pressure. Answer: A. High PEEP can increase intrathoracic pressure and influence the measured CVP. Rationale: CVP is affected by intrathoracic pressure. Positive pressure ventilation, particularly elevated PEEP, can increase intrathoracic pressure and raise the measured CVP. Therefore, CVP must be interpreted within the context of ventilatory settings and the client's overall clinical condition rather than being treated as a direct measurement of intravascular volume. Question 15. A nurse is caring for a client with suspected septic shock. The client has a MAP of 58 millimeters of mercury, CVP of 4 millimeters of mercury, HR of 128 per minute, temperature of 39.2 degrees Celsius, warm flushed skin, bounding peripheral pulses, and urine output of 18 milliliters per hour. Which pathophysiologic process most directly explains the low MAP despite the client's warm extremities and bounding pulses? A. Severe reduction in right ventricular contractility. B. Increased systemic vascular resistance causing excessive arterial pressure. C. Systemic vasodilation causing reduced vascular tone and decreased effective perfusion pressure. D. Increased venous return causing excessive preload. Answer: C. Systemic vasodilation causing reduced vascular tone and decreased effective perfusion pressure. Rationale: early distributive shock, particularly septic shock, may present with profound vasodilation, warm skin, and bounding pulses. The reduction in systemic vascular resistance decreases arterial pressure and can produce a low MAP despite relatively warm peripheral circulation. Ongoing oliguria demonstrates that effective organ perfusion remains compromised. Question 16. A client with acute decompensated heart failure has a CVP of 19 millimeters of mercury, MAP of 62 millimeters of mercury, respiratory rate of 32 per minute, and oxygen saturation of 86%. The client has severe dyspnea, bilateral crackles, and frothy sputum. The nurse notes that the healthcare provider has prescribed a loop diuretic and non-invasive positive pressure ventilation. Which finding most strongly supports the decision not to administer an additional routine crystalloid bolus? A. Heart rate of 108 per minute. B. CVP of 19 millimeters of mercury with pulmonary edema and severe respiratory distress. C. MAP of 62 millimeters of mercury. D. Respiratory rate of 32 per minute. Answer: B. CVP of 19 millimeters of mercury with pulmonary edema and severe respiratory distress. Rationale: the markedly elevated CVP together with pulmonary edema and severe respiratory distress indicates significant congestion. Additional crystalloid could worsen intravascular and pulmonary congestion. Although the low MAP remains concerning, the hemodynamic problem must be managed without automatically assuming that more fluid is needed. Question 17. A client with traumatic blood loss is receiving massive transfusion. The nurse notes a MAP of 61 millimeters of mercury and CVP of 4 millimeters of mercury. After several units of blood products, the MAP increases to 73 millimeters of mercury and CVP increases to 8 millimeters of mercury. However, the client remains confused and urine output remains 10 milliliters per hour. Which action is most appropriate? A. Conclude that perfusion has completely normalized because the MAP is above 65 millimeters of mercury. B. Stop all hemodynamic monitoring because the CVP is now within an expected range. C. Recognize that persistent evidence of organ hypoperfusion requires continued assessment despite improved pressure measurements. D. Administer additional fluid solely to increase the CVP above 10 millimeters of mercury. Answer: C. Recognize that persistent evidence of organ hypoperfusion requires continued assessment despite improved pressure measurements. Rationale: although the MAP and CVP have improved, persistent confusion and severe oliguria indicate that tissue perfusion may remain inadequate. Hemodynamic numbers should be interpreted alongside clinical indicators of organ function. A MAP above a commonly used threshold does not guarantee adequate perfusion in every client. Question 18. A client with acute right ventricular infarction has a CVP of 14 millimeters of mercury and MAP of 60 millimeters of mercury. The client has clear lung sounds, no pulmonary edema, and marked hypotension. The healthcare provider considers cautious fluid administration. Which explanation best describes why the client may have an elevated CVP despite requiring careful volume optimization? A. Right ventricular dysfunction can cause blood to accumulate in the systemic venous circulation while forward flow remains impaired. B. A high CVP always means that left ventricular output is increased. C. CVP becomes unreliable whenever the MAP is below 65 millimeters of mercury. D. Elevated CVP indicates that systemic vascular resistance is necessarily increased. Answer. A. Right ventricular dysfunction can cause blood to accumulate in the systemic venous circulation while forward flow remains impaired. Rationale. Right ventricular infarction can impair the right ventricle's ability to move venous blood forward into the pulmonary circulation. This can result in elevated right-sided filling pressure and systemic venous congestion despite inadequate cardiac output. The absence of pulmonary edema can occur because the primary problem involves the right ventricle. Question 19. A nurse obtains a blood pressure of 76/44 millimeter of mercury from an arterial catheter. The monitor displays a map of 55 millimeters of mercury. The client is lethargic and has a urine output of 5 milliliters per hour. The nurse notices that the arterial waveform appears dampened and the pressure tubing contains a visible air bubble. What should the nurse do first? A. Immediately increase the prescribed vasopressor dose. B. Administer a rapid crystalloid bolus. C. Confirm and correct the arterial monitoring system before basing treatment decisions on the questionable pressure reading. D. Document the MAP as 55 millimeters of mercury and continue routine monitoring. Answer. C. Confirm and correct the arterial monitoring system before basing treatment decisions on the questionable pressure reading. Rationale. A dampened waveform and air bubble can produce inaccurate arterial pressure measurements. Before escalating treatment based on an unreliable value, the nurse should assess the monitoring system, tubing, connections, and transducer setup. If the client is clinically unstable, assessment and intervention occur concurrently, but an obviously compromised monitoring system must be corrected promptly. Question 20. A client with septic shock is receiving norepinephrine. The nurse observes the following trend over 2 hours. Which conclusion is most appropriate? A. The increase in CVP proves that the client has become fluid overloaded. B. The overall trend indicates improved systemic perfusion and hemodynamic stability. C. The reduction in heart rate indicates worsening compensatory response. D. The MAP is now dangerously high and requires immediate reduction. Answer. B. The overall trend indicates improved systemic perfusion and hemodynamic stability. Rationale. The MAP has improved, heart rate has decreased, urine output has increased, and mental status has normalized. Together, these findings indicate improved systemic perfusion. The modest CVP increase must be interpreted within the overall clinical trend and does not, by itself, establish fluid overload. Question 21. A 59-year-old client with septic shock has received initial fluid resuscitation and is receiving norepinephrine. The nurse reviews the following hemodynamic measurements. CVP, 11 millimeters of mercury. MAP, 68 millimeters of mercury. HR, 112 per minute. Urine output, 8 milliliters per hour. Lactate, 5.2 millimoles per liter. Skin, cool and mottled. Mental status, increasingly confused. The healthcare provider states, the MAP is now above 65 millimeters of mercury, so the client's perfusion problem has been corrected. Which nursing response is most appropriate? A. The elevated CVP confirms that the client has adequate circulating volume. B. The MAP is acceptable, but the oliguria, elevated lactate, mottling, and confusion indicate persistent tissue hypoperfusion. C. The client is stable because the MAP is more important than all other perfusion findings. D. The CVP should be reduced below 5 millimeters of mercury before organ perfusion can improve. Answer. B. The MAP is acceptable, but the oliguria, elevated lactate, mottling, and confusion indicate persistent tissue hypoperfusion. Rationale. A MAP of approximately 65 millimeters of mercury or greater is commonly used as an initial target in many adults with septic shock, but achieving the pressure target does not guarantee adequate microcirculatory, or organ perfusion. Persistent oliguria, altered mental status, elevated lactate, and mottled skin indicate ongoing tissue hypoperfusion and require continued evaluation. Question 22. A client with acute blood loss has a CVP of 2 mm of mercury and MAP of 54 mm of mercury. The client is tachycardic, pale, cool, and producing 10 milliliters per hour of urine. After a fluid challenge, the CVP rises to 5 mm of mercury and the MAP increases to 66 mm of mercury. Which additional finding would provide the strongest evidence that the client is responding appropriately to the intervention? A. Heart rate decreases from 132 per minute to 108 per minute. B. CVP increases from 5 mm of mercury to 7 mm of mercury. C. Respiratory rate increases from 22 per minute to 30 per minute. D. Peripheral edema develops. Answer: A. Heart rate decreases from 132 per minute to 108 per minute. Rationale: a decrease in compensatory tachycardia following restoration of circulating volume, together with improvement in MAP, supports a favorable response. Peripheral edema would suggest excessive fluid accumulation, while a further CVP increase alone would not establish improved cardiac output or organ perfusion. Question 23. A mechanically ventilated client with severe pneumonia has a CVP of 15 mm of mercury. The nurse observes that the client is receiving a high level of PEEP and has a blood pressure of 86/48 mmHg. The provider asks whether the elevated CVP means the client should receive additional fluid. Which response is most appropriate? A. Yes. A CVP above 12 mm of mercury always indicates inadequate circulating volume. B. No. The elevated CVP proves that the client is fluid overloaded. C. The CVP should be interpreted in the context of PEEP and other clinical findings because increased intrathoracic pressure can elevate CVP. D. CVP is not affected by mechanical ventilation and can be used independently to determine fluid needs. Answer: C. The CVP should be interpreted in the context of PEEP and other clinical findings because increased intrathoracic pressure can elevate CVP. Rationale: positive pressure ventilation and elevated PEEP can increase intrathoracic pressure and consequently raise measured CVP. CVP is therefore influenced by factors other than circulating volume. The nurse should consider the client's ventilatory settings, cardiac function, perfusion findings, and overall response to previous interventions before determining whether additional fluid is appropriate. Question 24. A client in the ICU has an arterial pressure of 140th mmHg and a MAP of approximately 60 mm of mercury. The client is awake but reports dizziness when repositioned. Urine output is 18 milliliters per hour. The healthcare provider asks the nurse to evaluate the adequacy of the client's current perfusion. Which finding would be most concerning? A. Pulse pressure of 60 millimeters of mercury. B. Heart rate of 96 per minute. C. MAP of approximately 60 millimeters of mercury accompanied by oliguria and dizziness. D. Systolic pressure of 100 millimeters of mercury. Answer: C. MAP of approximately 60 millimeters of mercury accompanied by oliguria and dizziness. Rationale: the combination of a low MAP with clinical evidence of inadequate perfusion is concerning. Oliguria suggests impaired renal perfusion, while dizziness may indicate inadequate cerebral perfusion or reduced blood pressure tolerance. The systolic pressure alone does not adequately characterize systemic perfusion. Question 25. A client with acute decompensated heart failure has a CVP of 17 millimeters of mercury, MAP of 67 millimeters of mercury, pulmonary crackles, JVD, and increasing peripheral edema. The nurse administers the prescribed diuretic. 4 hours later, the CVP is 12 millimeters of mercury, MAP is 70 millimeters of mercury, oxygen saturation has improved, and urine output has increased substantially. Which interpretation is most appropriate? A. The decrease in CVP with improved oxygenation and urine output suggests reduced venous congestion and improved clinical status. B. The decrease in CVP proves that the client has developed severe intravascular depletion. C. The MAP increase indicates that the diuretic has caused systemic hypertension. D. The initial CVP of 17 millimeters of mercury was evidence of severe hypovolemia. Answer: A. The decrease in CVP with improved oxygenation and urine output suggests reduced venous congestion and improved clinical status. Rationale: the client initially had evidence of elevated filling pressure and systemic congestion. After diuresis, the CVP decreased while oxygenation and urine output improved and the MAP remained stable. This pattern supports a beneficial reduction in congestion rather than evidence of harmful volume depletion. Question 26. A client with suspected hypovolemic shock has a BP of 8246 mmHg, MAP of 58 millimeters of mercury, CVP of 3 millimeters of mercury, HR of 124 per minute, and urine output of 8 milliliters per hour. The client has cool skin and delayed capillary refill. Which hemodynamic change would the nurse expect if appropriate volume replacement successfully restores preload? A. CVP decreases further while MAP remains unchanged. B. CVP increases modestly with improvement in MAP and urine output. C. MAP decreases as CVP rises because venous return becomes impaired. D. CVP increases markedly while urine output decreases. Answer: B. CVP increases modestly with improvement in MAP and urine output. Rationale: in hypovolemia, appropriate volume replacement can increase venous return and preload. A favorable response may include a modest increase in CVP accompanied by improved arterial pressure, urine output, and other indicators of tissue perfusion. The clinical response is more meaningful than the CVP value alone. Question 27. A client with cardiogenic shock has a MAP of 52 millimeters of mercury and CVP of 18 millimeters of mercury. The nurse notes severe pulmonary congestion and cool extremities. An order is received to administer a large volume crystalloid bolus rapidly. Which action by the nurse is most appropriate? A. Administer the entire bolus rapidly because the MAP is below 65 millimeters of mercury. B. Hold the bolus and notify the healthcare provider about the combination of high CVP and pulmonary congestion. C. Place the client in Trendelenburg position before beginning the bolus. D. Increase oral fluid intake while waiting for the provider's response. Answer: B. Hold the bolus and notify the healthcare provider about the combination of high CVP and pulmonary congestion. Rationale: the client has a markedly elevated CVP, pulmonary congestion, and severe hypotension, suggesting cardiogenic shock with impaired forward flow rather than uncomplicated volume depletion. A large fluid bolus could worsen pulmonary edema. The prescription should be clarified in light of the client's current hemodynamic condition. Question 28. A nurse is reviewing the hemodynamic trend of a client after initiation of vasopressor therapy. Which change would indicate the least convincing evidence of improved tissue perfusion? A. Urine output increases from 10 to 35 milliliters per hour. B. Mental status changes from confused to oriented. C. Serum lactate begins to decrease. D. MAP increases from 58 to 68 millimeters of mercury, while urine output and mental status remain unchanged. Answer: D. MAP increases from 58 to 68 millimeters of mercury, while urine output and mental status remain unchanged. Rationale: an increase in MAP is important, but it does not by itself prove that tissue perfusion has improved. If urine output and mental status remain abnormal, evidence of end-organ perfusion remains concerning. The other findings directly demonstrate improvement in organ function or cellular perfusion. Question 29. A client with severe sepsis has a CVP of 4 millimeters of mercury, MAP of 61 millimeters of mercury, HR of 122 per minute, and urine output of 12 milliliters per hour. After receiving fluid resuscitation, the CVP increases to 10 millimeters of mercury, but the MAP remains 60 millimeters of mercury and urine output remains unchanged. The client develops increasing pulmonary crackles. Which interpretation is most appropriate? A. The fluid administration clearly restored adequate systemic perfusion. B. The unchanged MAP and urine output indicate that the increased CVP did not translate into adequate improvement in organ perfusion. C. The client requires unlimited additional crystalloid because the MAP remains low. D. The increase in CVP proves that cardiac output has normalized. Answer: B. The unchanged MAP and urine output indicate that the increased CVP did not translate into adequate improvement in organ perfusion. Rationale: the CVP increased substantially, but the MAP and urine output failed to improve, while pulmonary congestion developed. This indicates that additional filling pressure did not produce a meaningful improvement in systemic perfusion and may be contributing to fluid-related complications. Question 30. A client with severe septic shock is receiving norepinephrine. The nurse obtains a BP of 108.46 mmHg, MAP of 67 mm of mercury, CVP of 8 mm of mercury, HR of 104 per minute, urine output of 50 milliliters per hour, and an improving mental status. The nurse compares these findings with measurements obtained 2 hours earlier, when the MAP was 55 millimeters of mercury and urine output was 12 milliliters per hour. Which conclusion is most appropriate? A. The client demonstrates improving systemic perfusion based on the overall hemodynamic and clinical trend. B. The client is deteriorating because the CVP increased from 5 to 8 millimeters of mercury. C. The client is experiencing fluid overload because the MAP is above 65 millimeters of mercury. D. The client has inadequate perfusion because the systolic pressure remains below 120 millimeters of mercury. Answer: A. The client demonstrates improving systemic perfusion based on the overall hemodynamic and clinical trend. Rationale: the MAP has improved from 55 to 67 millimeters of mercury, urine output has increased substantially, and mental status is improving. These findings collectively support improved systemic and end-organ perfusion. The modest CVP increase does not independently indicate fluid overload, and a systolic pressure below 120 millimeters of mercury is not inherently evidence of inadequate perfusion. Question 31. A 70-year-old client with severe pneumonia develops septic shock and requires mechanical ventilation. The nurse notes a MAP of 57 millimeters of mercury, CVP of 6 millimeters of mercury, heart rate of 124 per minute, urine output of 9 milliliters per hour, and new confusion. After initiation of norepinephrine, the MAP increases to 72 millimeters of mercury. However, the client remains confused and urine output remains 10 milliliters per hour. The nurse reviews the arterial waveform and confirms that the MAP measurement is accurate. Which interpretation is most appropriate? A. The client has definitely achieved adequate tissue perfusion because the MAP is now above 65 millimeters of mercury. B. The persistent oliguria and altered mental status indicate that organ perfusion may remain inadequate despite improvement in MAP. C. The CVP of 6 millimeters of mercury proves that additional fluid administration is required. D. The norepinephrine should be discontinued immediately because the MAP has increased. Answer: B. The persistent oliguria and altered mental status indicate that organ perfusion may remain inadequate despite improvement in MAP. Rationale: a MAP target is an important component of shock management, but achieving a numerical target does not guarantee adequate perfusion of every organ. Persistent oliguria and altered mental status indicate ongoing renal and cerebral perfusion abnormalities. The client requires continued evaluation of the overall hemodynamic and clinical picture. Question 32. A client is admitted following massive gastrointestinal hemorrhage. The initial CVP is 1 millimeter of mercury, MAP is 51 millimeters of mercury, HR is 136 per minute, and urine output is 7 milliliters per hour. After administration of blood products, the CVP increases to 6 millimeters of mercury and the MAP increases to 65 millimeters of mercury. The client becomes less tachycardic and urine output begins to increase. Which physiological change most directly explains the improvement in cardiac output? A. Decreased venous return to the right atrium. B. Increased systemic vascular resistance caused by blood loss. C. Increased ventricular filling resulting from improved venous return. D. Decreased myocardial oxygen delivery caused by restoration of blood volume. Answer: C. Increased ventricular filling resulting from improved venous return. Rationale: restoration of circulating volume increases venous return and ventricular filling. In a client whose cardiac function is responsive to preload, improved ventricular filling can increase stroke volume and cardiac output through the Frank-Starling mechanism. The accompanying improvement in MAP, heart rate, and urine output supports a favorable response. Question 33. A client with acute respiratory distress syndrome is receiving high PEEP. The nurse observes a CVP of 16 millimeters of mercury, MAP of 59 millimeters of mercury, and declining urine output. The client has no peripheral edema and no evidence of recent fluid administration. Which mechanism could contribute to this combination of findings? A. Increased intrathoracic pressure may elevate CVP while reducing venous return and cardiac output. B. High PEEP always increases venous return and cardiac output. C. Elevated CVP caused by PEEP proves that the client has excess circulating volume. D. PEEP affects pulmonary pressure but cannot influence right-sided filling pressure. Answer. A. Increased intrathoracic pressure may elevate CVP while reducing venous return and cardiac output. Rationale. High levels of PEEP can increase intrathoracic pressure. This can increase measured CVP while simultaneously reducing the pressure gradient for venous return, potentially decreasing preload and cardiac output. Consequently, an elevated CVP in a mechanically ventilated client does not necessarily represent excessive intravascular volume. Question 34. A client with acute myocardial infarction has a MAP of 54 millimeters of mercury and CVP of 15 millimeters of mercury. The client is pale, cool, confused, and has bilateral pulmonary crackles. Which assessment finding would most strongly support cardiogenic shock rather than uncomplicated hypovolemic shock? A. Heart rate of 124 per minute. B. Urine output of 10 milliliters per hour. C. Cool extremities. D. Elevated CVP accompanied by pulmonary congestion. Answer. D. Elevated CVP accompanied by pulmonary congestion. Rationale. Hypovolemic shock typically produces reduced filling pressures. In contrast, cardiogenic shock can produce elevated filling pressures because the failing heart cannot effectively eject blood. The combination of high CVP and pulmonary congestion strongly supports impaired cardiac pump function. Question 35. A client with septic shock has a CVP of 5 millimeters of mercury and MAP of 60 millimeters of mercury. After fluid administration, the CVP rises to 12 millimeters of mercury, while the MAP increases only to 62 millimeters of mercury. The client develops new crackles and oxygen saturation decreases. Which conclusion should the nurse make? A. The client has demonstrated an ideal response to fluid therapy. B. The increase in CVP proves that tissue perfusion has normalized. C. Further rapid fluid administration may worsen congestion without providing adequate improvement in systemic perfusion. D. The client should receive additional fluid until the CVP reaches 15 millimeters of mercury. Answer. C. Further rapid fluid administration may worsen congestion without providing adequate improvement in systemic perfusion. Rationale. The CVP increased substantially, but the MAP improved minimally and pulmonary congestion developed. This suggests that additional volume is increasing filling pressure without producing an adequate improvement in systemic perfusion. Further fluid administration should therefore be carefully reconsidered. Question 36. A critically ill client has a BP of 86 to 44 mmHg. The nurse calculates the MAP using the formula. MAP equals SBP plus 2 times DBP divided by 3. Which MAP should the nurse document? A. 58 millimeters of mercury. B. 63 millimeters of mercury. C. 66 millimeters of mercury. D. 72 millimeters of mercury. Answer. B. 58 millimeters of mercury. Rationale. Using the formula. MAP equals open parenthesis 86 plus 2 times 44 close parenthesis divided by 3. MAP equals open parenthesis 86 plus 88 close parenthesis divided by 3. MAP equals 174 divided by 3. MAP equals 58 millimeters of mercury. A MAP at this level is concerning for inadequate systemic perfusion, particularly when accompanied by clinical evidence of shock. Question 37. A client with severe sepsis has a CVP of 13 millimeters of mercury, MAP of 63 millimeters of mercury, HR of 118 per minute, and urine output of 12 milliliters per hour. The client has received substantial fluid resuscitation. The nurse notes increasing peripheral edema, but no improvement in urine output or mental status. Which finding is most important when determining whether additional fluid should be administered? A. The client's elevated CVP should be considered together with the lack of improvement in organ perfusion. B. The heart rate is elevated, so additional fluid is automatically indicated. C. Peripheral edema confirms that the client has adequate tissue perfusion. D. The CVP must be reduced below 5 millimeters of mercury before any vasoactive medication can be given. Answer: A. The client's elevated CVP should be considered together with the lack of improvement in organ perfusion. Rationale: the client has already received substantial fluid, has elevated CVP and edema, yet continues to demonstrate poor organ perfusion. This raises concern for fluid intolerance or ineffective volume expansion. Additional fluid should not be administered solely because perfusion remains poor. The underlying cause and alternative interventions must be evaluated. Question 38. A client with severe hypotension has an arterial blood pressure of 80/40 millimeter of mercury and a CVP of 2 millimeters of mercury. The nurse notes that the client is awake, warm, and producing 35 milliliters per hour of urine. The provider asks whether the MAP is acceptable. Which response is most accurate? A. Yes. A systolic pressure of 80 millimeters of mercury is adequate as long as the client is awake. B. Yes. The CVP is low, so the MAP does not need to be considered. C. The MAP is approximately 53 millimeters of mercury, which is concerning even though some clinical indicators of perfusion appear preserved. D. The MAP cannot be calculated when the CVP is below 5 millimeters of mercury. Answer: C. The MAP is approximately 53 millimeters of mercury, which is concerning even though some clinical indicators of perfusion appear preserved. Rationale: MAP equals open parenthesis 80 plus 2 times 40 close parenthesis divided by 3 is equal to 160 divided by 3 equals 53 millimeters of mercury. This is substantially below the commonly used initial target of approximately 65 millimeters of mercury in many critically ill adults. Although the client's current urine output and mental status are reassuring, the markedly low MAP requires prompt assessment and management. Question 39. A client with right-sided heart failure has a CVP of 20 millimeters of mercury and MAP of 68 millimeters of mercury. The client develops worsening peripheral edema, ascites, hepatomegaly, and decreased urine output. Which physiological process most likely contributes to the elevated CVP? A. Increased left ventricular ejection caused by excessive preload. B. Impaired right ventricular forward flow resulting in systemic venous congestion. C. Severe reduction in systemic venous pressure. D. Increased renal filtration caused by improved cardiac output. Answer: B. Impaired right ventricular forward flow resulting in systemic venous congestion. Rationale: right ventricular dysfunction can impair forward movement of blood into the pulmonary circulation. This causes blood to accumulate in the systemic venous system, increasing right-sided filling pressure and producing manifestations such as JVD, edema, ascites, hepatomegaly, and elevated CVP. Question 40. A client with septic shock has been receiving norepinephrine for several hours. The nurse observes: MAP, 74 millimeters of mercury. CVP, 7 millimeters of mercury. HR, 98 per minute. Urine output, 45 milliliters per hour. Lactate, decreasing. Mental status, alert. Extremities, warmer than previously. Which finding provides the strongest evidence that the client's perfusion is improving? A. CVP of 7 millimeters of mercury. B. Heart rate of 98 per minute. C. MAP of 74 millimeters of mercury. D. Decreasing lactate with improved urine output and mental status. Answer: D. Decreasing lactate with improved urine output and mental status. Rationale: the strongest evidence of improved tissue perfusion comes from improvement in end organ and metabolic indicators. Decreasing lactate, increased urine output, and improved mental status collectively indicate improved systemic and cellular perfusion. MAP and CVP are important hemodynamic measurements, but should be interpreted alongside these clinical indicators. Question 41. A 67-year-old client is admitted to the ICU following emergency surgery for a ruptured abdominal aneurysm. The client required significant blood product replacement and remains mechanically ventilated. Current hemodynamic measurements are BP 88/50 mm of mercury, MAP 64 mm of mercury, CVP 13 mm of mercury, HR 118 per minute, urine output 12 milliliters per hour. Skin cool and mottled. The nurse compares these values with those obtained 1 hour earlier. CVP 7 mm of mercury and MAP 70 mm of mercury. No additional fluid has been administered during the interval. Which explanation should the nurse consider most strongly? A. The increase in CVP proves that circulating blood volume has increased. B. The falling MAP with rising CVP may indicate worsening cardiac function or increased intrathoracic pressure rather than simple volume depletion. C. The elevated CVP confirms that renal perfusion has improved. D. The client's low MAP is expected because the CVP is elevated. Answer: B. The falling MAP with rising CVP may indicate worsening cardiac function or increased intrathoracic pressure rather than simple volume depletion. Rationale: a rising CVP accompanied by a falling MAP is not the classic pattern of uncomplicated hypovolemia. It may occur with impaired right-sided cardiac function, increased intrathoracic pressure, excessive positive pressure ventilation, or other causes of impaired forward flow. The declining urine output and mottling further indicate worsening perfusion. Question 42. A client with septic shock has a MAP of 61 mm of mercury and CVP of 6 mm of mercury. The client receives a prescribed fluid bolus. Following the intervention, the MAP increases to 70 mm of mercury, CVP to 8 mm of mercury, and urine output from 15 milliliters per hour to 42 milliliters per hour. Which physiological principle best explains the improvement in cardiac output following restoration of circulating volume? A. Reduced preload causes increased ventricular contraction. B. Increased venous return increases ventricular filling and can increase stroke volume when the heart is preload responsive. C. Increased CVP directly causes systemic vasoconstriction. D. Increased arterial pressure automatically increases circulating blood volume. Answer: B. Increased venous return increases ventricular filling and can increase stroke volume when the heart is preload responsive. Rationale: when a client is preload responsive, increased venous return increases ventricular filling. Within the appropriate portion of the Frank-Starling relationship, this can increase stroke volume and cardiac output. The improved MAP and urine output provide clinical evidence that the intervention benefited systemic perfusion. Question 43. A client with cardiogenic shock has a CVP of 18 mm of mercury and MAP of 57 mm of mercury. The client is receiving mechanical ventilation and has bilateral pulmonary crackles. The nurse receives a prescription to increase the rate of an isotonic crystalloid infusion. Which finding should cause the nurse to question the prescription most urgently? A. HR of 110 per minute. B. Urine output of 20 milliliters per hour. C. CVP of 18 mm of mercury with pulmonary congestion and persistent hypotension. D. Respiratory rate of 24 per minute. Answer: C. CVP of 18 mm of mercury with pulmonary congestion and persistent hypotension. Rationale: the combination of markedly elevated CVP, pulmonary congestion, and hypotension strongly suggests impaired cardiac pumping with venous congestion. Increasing fluid administration may worsen pulmonary edema without adequately improving forward cardiac output. The provider should be informed of the current hemodynamic pattern. Question 44. A critically ill client has a BP of 120/36 mmHg. The nurse calculates the MAP as approximately 64 mm of mercury. The client is alert and has urine output of 35 milliliters per hour. Which statement about this client's hemodynamic status is most accurate? A. The systolic pressure alone establishes that organ perfusion is adequate. B. The map is approximately 64 millimeters of mercury and should be interpreted with the client's clinical indicators of perfusion. C. The diastolic pressure of 36 millimeters of mercury proves that cardiac output is absent. D. The client is necessarily experiencing hypovolemic shock because the pulse pressure is wide. Answer. B. The map is approximately 64 millimeters of mercury and should be interpreted with the client's clinical indicators of perfusion. Rationale. Map is approximately open parenthesis 120 plus 2 times 36 close parenthesis divided by 3 is equal to 192 divided by 3 is equal to 64 mmHg. Although this is close to the commonly used initial target of approximately 65 millimeters of mercury, the adequacy of perfusion should be assessed using the entire clinical picture. The systolic pressure alone cannot establish adequate tissue perfusion. Question 45. A client with severe sepsis has received substantial fluid resuscitation. The current CVP is 14 millimeters of mercury, MAP is 59 millimeters of mercury, urine output is 8 milliliters per hour, and lactate is rising. The client develops bilateral crackles and increasing oxygen requirements. Which assessment finding would most strongly suggest that further fluid administration is unlikely to be beneficial? A. Persistent hypotension despite elevated filling pressure and worsening pulmonary congestion. B. Heart rate of 120 per minute. C. Temperature of 39 degrees Celsius. D. CVP of 14 millimeters of mercury by itself. Answer. A. Persistent hypotension despite elevated filling pressure and worsening pulmonary congestion. Rationale. The client has elevated filling pressure but remains hypotensive and poorly perfused while developing pulmonary congestion. This suggests that additional fluid is increasing venous pressure without adequately improving forward flow. The underlying shock physiology and need for vasoactive or other advanced therapies should be reassessed. Question 46. A nurse is evaluating a client with suspected hypovolemic shock. Which set of hemodynamic findings is most consistent with decreased preload caused by intravascular volume loss? A. CVP 16 millimeters of mercury, MAP 58 millimeters of mercury, pulmonary crackles. B. CVP 12 millimeters of mercury, MAP 70 millimeters of mercury, JVD. C. CVP 3 millimeters of mercury, MAP 56 millimeters of mercury, tachycardia, oliguria, and cool skin. D. CVP 18 millimeters of mercury, MAP 72 millimeters of mercury, peripheral edema. Answer. C. CVP 3 millimeters of mercury, MAP 56 millimeters of mercury, tachycardia, oliguria, and cool skin. Rationale. A low CVP combined with hypotension, tachycardia, oliguria, and cool skin is consistent with reduced venous return and decreased preload. The other patterns include elevated filling pressures or evidence of venous congestion. Question 47. A client with septic shock has a MAP of 54 millimeters of mercury. A norepinephrine infusion is initiated, and the MAP rises to 69 millimeters of mercury. The nurse notes that the client's hands remain cool, urine output is still 10 milliliters per hour, and the client remains confused. Which action is most appropriate? A. Document that perfusion has normalized because the MAP is above 65 millimeters of mercury. B. Continue evaluating for persistent tissue hypoperfusion and other causes of inadequate organ perfusion. C. Discontinue norepinephrine immediately because the MAP increased. D. Administer a large fluid bolus solely because the hands remain cool. Answer. B. Continue evaluating for persistent tissue hypoperfusion and other causes of inadequate organ perfusion. Rationale. The improved MAP is encouraging, but persistent oliguria, confusion, and cool extremities indicate that adequate organ perfusion has not necessarily been restored. The nurse should continue assessing the overall hemodynamic response and communicate persistent evidence of hypoperfusion. Question 48. A client with acute right ventricular failure has a CVP of 19 millimeters of mercury, MAP of 65 millimeters of mercury, and urine output of 15 milliliters per hour. The client has severe JVD, hepatomegaly, ascites, and peripheral edema, but relatively clear lung sounds. Which finding best explains why pulmonary edema may be less prominent in this client despite the markedly elevated CVP. A. The elevated CVP indicates that the left ventricle is ejecting excessive blood. B. Right ventricular dysfunction primarily produces systemic venous congestion, which may occur without primary left-sided pulmonary congestion. C. Pulmonary edema always occurs whenever CVP exceeds 15 millimeters of mercury. D. Clear lung sounds prove that the CVP measurement is inaccurate. Answer: B. Right ventricular dysfunction primarily produces systemic venous congestion, which may occur without primary left-sided pulmonary congestion. Rationale: right ventricular failure causes blood to accumulate in the systemic venous circulation, producing JVD, hepatomegaly, ascites, and peripheral edema. Pulmonary edema is more directly associated with elevated left-sided filling pressures. Therefore, severe systemic venous congestion can occur with relatively clear lungs. Question 49. A client with septic shock is being monitored continuously. The nurse reviews the following trend. The client is now awake, has warmer extremities, and the serum lactate is decreasing. Which conclusion is most appropriate? A. The rising CVP proves progressive fluid overload. B. The client is developing cardiogenic shock because the CVP increased. C. The overall trend indicates improved hemodynamics and organ perfusion. D. The MAP is becoming dangerously elevated and requires immediate reduction. Answer: C. The overall trend indicates improved hemodynamics and organ perfusion. Rationale: the client demonstrates simultaneous improvement in MAP, urine output, mental status, peripheral perfusion, and lactate. The modest increase in CVP occurs alongside improved perfusion rather than deterioration. The overall trend therefore supports a favorable hemodynamic response. Question 50. A 75-year-old client with septic shock has received initial fluid resuscitation and is receiving norepinephrine. The nurse obtains the following measurements. BP, 96/48 mmHg. MAP, 64 millimeters of mercury. CVP, 12 millimeters of mercury. HR, 106 per minute. Urine output, 12 milliliters per hour. Lactate, 4.8 millimoles per liter. Mental status, confused. Lungs, new bilateral crackles. The nurse reviews the previous measurements and notes that before fluid resuscitation the CVP was 5 millimeters of mercury and MAP was 58 millimeters of mercury. The MAP improved only minimally while the CVP increased substantially and pulmonary congestion developed. Which interpretation is most appropriate? A. The client has demonstrated a clear need for additional large-volume crystalloid because the MAP remains below 65 millimeters of mercury. B. The increase in CVP proves that cardiac output has normalized. C. The client has adequate perfusion because the MAP is now close to 65 millimeters of mercury. D. The limited MAP response, persistent organ hypoperfusion, rising CVP, and pulmonary congestion suggest that additional fluid may be harmful and that alternative hemodynamic support should be evaluated. Answer: D. The limited MAP response, persistent organ hypoperfusion, rising CVP, and pulmonary congestion suggest that additional fluid may be harmful and that alternative hemodynamic support should be evaluated. Rationale: the client has not demonstrated an adequate response to fluid administration. CVP increased substantially, but MAP improved only minimally, while oliguria, confusion, elevated lactate, and pulmonary congestion persist. This suggests that increasing filling pressure has not translated into adequate systemic perfusion and that further fluid could worsen congestion. The healthcare team should reassess the cause of shock and consider appropriate vasoactive or other advanced hemodynamic support. That's the end of the 50 hemodynamic monitoring questions. If you can confidently interpret CVP, MAP, preload, perfusion, and changing hemodynamic trends, you're strengthening a critical area of ICU and NCLEX preparation. Review the questions you missed, understand why the correct answers were correct, and keep practicing until these decisions become automatic.